So good evening, everybody. Welcome to today's meeting. It is November. Beware and be aware of urological cancers. It has been arranged by the Society of Genitourinary Oncology. And this would be a nice session. We have a good lineup of all the urological cancers and what awareness or what small changes in early diagnosis screening have happened, and we all need to be updated about it. So I welcome our president, Dr. Jagdeesh Kulkarni, to have say a few words about today's opening remarks, and welcome everybody.
Good evening. I note that this is the first webinar after our first annual Congress, which was held in August 2022, which was a great success. Having said that, I have got a very good news that SOGO has been now included in World Uro-Oncology Federation at SIU meeting 2 weeks ago. And that's where we are going to be one more society in addition. It's not an individual membership, but a society membership. Okay. Now coming to the today's webinar, which perhaps would be the last of this year, 2022, and the topic is very interesting. Beware and be aware. Although I know November is a men's health month, and we must look at the cancer. As I see, the program has been very well done. Only thing which I was trying to find out whether upper urothelial tract, which is more dangerous than the bladder cancer, perhaps that could have been added, but I think during discussion you could have that. Otherwise, everything has been covered. I think with this remark, I think we are looking forward to a very good discussion over next 90 minutes. Thank you very much.
Thank you, sir. And I invite our President-elect, Dr. Sudhir Raval, sir, also to say a very few words here. Sir is logged in.
Thank you, Ganesh. I think sir has, can you hear me?
Yes, sir. Okay.
Sir has said already, because this was first webinar after our SOGO annual conference, and the things are going in SOGO. I think we are going to be a very leading society in urological cancer, where all the people like medical, radiation, and the molecular, everybody is on the panel or are the members. So I hope that we continue our academic activities, and with that also do a lot of multi-center studies, which we had recently meeting with Murthy. So we should think of going in that direction more and more, so that we can make this society robust academic body, and also in future we should focus on journal also, as we suggested in SIU. Also, we had a small meeting. We just get together. So in that case, with this, I'll say that all the best, and it's a very good topic which you have chosen, and I can see that is going to be a great discussion on knowledge or knowledge sharing and update in the urological cancer. Thank you.
Thank you, sir. We all hope this goes as a good meeting today, and I invite the first speaker, Dr. N. Ragavan, who will speak on should we screen for urological cancers to begin with.
Thank you, Ganesh, and my most sincere wishes to President and President-elect, and to all the friends who are assembled here. So when we discussed about this, a basic question came to our mind: should we screen for urological cancers? And the moment we say about urological cancers, then we say, oh, screening for urological cancers has been tested already in prostate cancer. We know the famous European study and the US study, and the results all of us know. So the point of reference which I'm having is that, is urological cancer so important? If you go back to the old definition of screening, a screening should be done for a disease which has a proportion of mortality, a possibility of early detection, and a possibility of intent for cure. Does urological cancer fit into that? And there should be an easy screening tool. Say, for example, a simple test should detect the most of the cancer. If you look at that, I think urological cancer just fit into every of things. Let us take a simple example of penile and testicular cancer. All you need to do is a self-examination. Like breast self-examination, penile testicular self-examination is a simple tool to promote, to make people understand that a simple examination of yourself is good enough to pick up a cancer and come to a doctor if necessary. And does this cancer, these cancers, if detected early, have a curative intent? Answer is yes. And thirdly, is it easy to detect and treat the cancer? Answer is yes. So all this, the only thing is, this is not having an epidemiological proportion. It's not in a high incidence that we should be worried about. But it's such a simple tool to tell the people that it's such a easy intervention to do. Let's look at prostate cancer. We all know Globocon data is very clear. We in the developing countries, India and the subcontinent, almost the mortality rate of prostate cancer detected patient is 60% compared to 19 out of 20 patients who survive in US and UK. We have a different problem. So therefore, some form of screening, even it may not be the country-driven, government-driven screening program, at least a case detection program should be initiated at the level of the practicing doctors. Bladder cancer and the upper tract disease, as sir was mentioning, is an easy thing to screen for the simple reason, if a patient who finds hematuria doesn't say that it is because of a beetroot juice and turns up to the hospital, we have already diagnosed and treated that patient. Such simple take-home message will be a great intervention for us. So my point is, urological cancer are very nicely set up for a simple screening. And don't forget the kidney cancer. All we need to do is just a simple ultrasound scan. So urological cancers are very nicely set up for screening, at least case detection, early intervention, and excellent recovery from the disease. With those words, I'm going to hand over to Sanjay, who is going to tell, is this screening a success story or not? Sanjay.
Thank you very much, Dr. Ragavan. Just trying to address Dr. Kulkarni sir's, we tend to screen for cancers that are, as Raghu has said, more of epidemiological. Upper tract urothelial cancer is not that very common that we can screen for, and bladder cancer is a lot more common. So you always end up diagnosing a bladder cancer. I'm just going to cover 3 questions. These are the background information that I'm going to project the slides from. So how common is cancer? Patients keep on talking about it. And the first answer to that is depends on where you live. This is from Globocon 2020 data. So the highest incidence seems to be in the north, though they have taken Punjab and Delhi. It seems to be 1 in 7 to 1 in 8. If you go towards the northeast, it is almost 1 in 4, 1 in 5. Whereas the western part, especially this sort of a bit more rural area, it's 1 in 20. Whether we are picking up the cancers, that is different, but according to the Globocon data or according to the population-based cancer screening, if you say what is the cancer incidence currently in India, I would probably say 1 in 8 people tend to have similar male and female, 1 in 8 tend to have a cancer. That's the first question to be answered. What is the commonest cancer? 2020 was the first time wherein the breast cancer overtook cervical cancer or head and neck cancer. And now, though breast is there only in females, the commonest cancer among both sexes is breast cancer. The reason why I'm stressing that is cervical cancer is an infection-related cancer. Cervical cancer is related to a societal problem. Breast cancer, prostate cancer are metabolic problems. So we are moving towards the Western society problems, which are metabolic related. So the breast cancer, if you see, just for my state of Telangana, the cervical cancer is 8.7. This is 35.5. We are talking of factor of almost 4 times more common compared to cervical cancer. Yes, this would vary if you take other states, but I just wanted to make a statement that breast cancer is the commonest cancer. Why are we picking it up more? I would probably say we as a society has evolved, and that's where my success story is going to come from. There are 3 cancers currently we tend to screen for: oral cancer, cervical cancer, and breast cancer. And if you see this breast cancer, this is quite a simple visual screening for cervical cancer. And what it showed is 25% risk reduction in the cancer incidence and 35% reduction in mortality. And this is from Tamil Nadu, where probably the best implementation of cancer screening is conducted. So 35% reduction with whatever the resources crunch that is there. Still, we can show that if we do a proper screening for cervical cancer, we are able to achieve. And similar thing, meta-analysis of quite a few studies showing from Mumbai, again, the same number, around a third reduction in the mortality associated with cervical cancer. So if we do it as a population based, especially where the disease is significant, we can be successful. Then the next question is, why are we not successful? This is what Raghu was alluding to. This is according to the cancer registry. If you see, the commonest presentation is loco-regional, around 60%. Head and neck, this should be obvious. When you open your mouth, this should be obvious. Why are we still picking up 70% of the cancers in loco-regional state? Lung, you can understand. But these sort of cervix uteri, these sort of things, we should be picking up more of these cancers in the localized sector, whereas across board, we seem to be having loco-regional in around 60% of the cases. What is the reason for that? And it isn't lack of money. If you see Brazil, which is similar to us with respect to socioeconomic status, if you take Brazil, the poorest of Brazil still tend to have almost 80% pickup, 80% cervical cancer screening. They do have effective screening for 80%. And when you take the richest, it goes up to 100%. Whereas when you take India, the poorest, even if you take crude, it is 20%. And even in the rich people, it doesn't cross 50%. So it isn't lack of money. We don't seem to give it importance. That's the reason we are not picking it up. And that's what we need to improve. We need to improve the awareness. We need to keep on taking it to the society, saying that cancer is relevant for India because we are moving in from infection-related cancers to metabolic-related cancers. Thank you very much.
Thank you so much, Sanjay. And it was indeed a nice opening talk, kind of giving idea why we should do certain things about cancers. And I invite the next speaker, Dr. Tushar Aditya Narain, screening for prostate cancer in India. So
thank you very much, sir.
A very
yeah,
India
can you hear me?
Things.
Yeah. Can you hear me, sir?
Yes.
Thank you very much, sir. A very good evening to all my respected teachers and my colleagues, and a big thank you to Dr. Ragavan, Dr. Bakshi, and Dr. Addla, and the SOGO team for giving me this opportunity. Today evening, I would be talking on screening for prostate cancer in India. I am Tushar Aditya Narain, and I'm currently working at Medanta in Gurgaon. I'll start off with the global burden of prostate cancer. This map shows the prevalence of prostate cancer worldwide. The countries marked in green show that the prostate cancer is the most common cancer in those countries. Coming to the mortality data in these countries, lung cancer, which is depicted in blue, is the most common cause of mortality. But in these countries, prostate cancer is the second most common cause of mortality. In 2020, in US alone, there were 33,330 deaths, and there were 191,000 patients of prostate cancer. Coming to the incidence of prostate cancer, there has been a steep rise in the incidence of prostate cancer in the early 90s, which is explained by the introduction of PSA. And then it stabilized down to about 150 to 200 cases per 100,000. There's another dip in the number of cases in 2012. That was when the US Preventive Services Task Force gave a grade D recommendation, recommending against the use of screening for prostate cancer. Introduction of PSA has greatly increased the incidence of prostate cancer. It has resulted in a stage migration, but did it actually reduce the mortality due to prostate cancer? This was the million-dollar question. Two randomized controlled trials, the PLCO trial and the ERSPC trial, one in the US, one in the Europe, were almost simultaneously initiated to answer this question. The PLCO, the US trial, randomized about 76,000 patients to an annual PSA test for 6 years and a DRE annually for 4 years, while the European study randomized about 182,000 prostate cancer patients for a PSA screening done once every 4 years. The major objective of these two RCTs were to assess whether PSA screening had any effect on prostate cancer mortality. These were two very large randomized controlled trials, and it was expected that the results of these two trials would give us the answer. The interesting thing was that the results of these two trials were published in the same issue of New England Journal of Medicine in 2009. Let's see the results on the conclusion of the USA-based PLCO trial. The authors concluded that after 7 to 10 years of follow-up, the rate of death from prostate cancer was very low and did not differ significantly between the two study groups. There was no difference in mortality in the two groups according to the US study. Now coming to the European study, the authors concluded that the PSA-based screening reduced the rate of death from prostate cancer by 20%, but this was associated with a higher risk of diagnosis. Two RCTs, one in the US, one in the Europe. One said no difference, the other said there was a difference. And then we came back again to the same crossroads, whether there is any benefit of screening of prostate cancer or not. Both these studies have been criticized for different reasons. The US study was criticized for contamination because there was PSA screening in the control arm, and there was no organized screening in the intervention arm. The European study was criticized for being a multi-center, multi-nation study, wherein each center was following a different protocol. But for us, rational inference which we can derive is that the PLCO study shows that more versus less screening makes little difference to mortality, whereas the European study shows that screening versus no screening at all reduces prostate cancer mortality, although it is associated with a high risk of overdiagnosis. An in-depth analysis of the mortality data from the Rotterdam arm of the ER-SPC trial gave us the numbers needed to screen and the numbers needed to treat to prevent one prostate cancer death. A quick calculation brings us to the figure of about 1,410 patients which need to be screened to prevent one prostate cancer death, and 48 additional prostate cancer patients need to be treated to prevent one death. We have the late data from these two trials also. For the USA, the PLCO study, after 17 years of follow-up, there was still no significant reduction in prostate cancer mortality in the intervention arm. The late data from the ER-SPC trial maintains the same finding that PSA screening does result in improvement in the prostate cancer mortality. There's another trial called the TRAP trial. This is a UK-based trial, and this is the largest randomized controlled trial till date, which evaluated the role of a single PSA for screening for prostate cancer. It evaluated more than 400,000 patients across 573 centers in the UK, and the authors concluded that a single PSA screening intervention detected more prostate cancer cases for sure, but had no significant effect on prostate cancer mortality after a median follow-up of 10 years. So what do we infer from these trials? The risk of detecting a low-grade cancer has obviously increased with PSA screening. PSA screening infrequently finds high-grade tumors which are Gleason 8 and above because these are very rare, and when present, they progress rapidly and become clinically apparent. PSA screening decreases cancer mortality to some extent, although it is associated with a high risk of overdiagnosis and overtreatment. Giving a data to these overdiagnosis and overtreatment in the US, there is an overdiagnosis of about 23 to 42%, and in the Europe, it is about 66%. Coming to overtreatment, there's an overtreatment for 10% for surgery and 45% for radiotherapy. If you take a closer look, the rates of overtreatment in the US, whether surgery or radiotherapy, mirrors almost the rates of overdiagnosis in US. What does this mean? That every patient in US that is diagnosed with prostate cancer ends up receiving a treatment for the prostate cancer. And this was the main reason why the US Preventive Services Task Force gave a grade D recommendation recommending against PSA screening. Now, using PSA for screening, as we have already discussed, it brings in overdiagnosis and overtreatment, which brings with itself its own complications in the form of psychological implications. The patient has to live with prostate cancer. There's a financial burden, and obviously there are biopsy-related complications. For overtreatment, there is again a financial burden and the treatment-related side effects. What do the guidelines and the different societies say? As I've already mentioned, in the US Preventive Services Task Force advised against screening in 2012, but in 2018, they changed the recommendation to a grade C, which said that it could be offered to people on a case-to-case basis and has some benefit. All the rest of the organizations give the same recommendation, that it should be a shared decision-making with the patient, and the patient should be informed about the PSA screening and should be offered to patients beyond 50 years of age with a life expectancy of 10 to 15 years. Coming to the Indian data, what is the Indian perspective and where do we stand as compared to the West? Prostate cancer, as it stands in India, is very different from the prostate cancer as it stands in the US. In India, it's the 10th most common cause of cancer mortality, as against the second most common cause of cancer mortality in the USA. Even the incidence is very low in India. It's about 5 to 9.1 per 100,000 patients per year, where in the US, it's 110 for the whites and 180 for the blacks. So in India, the rate of prostate cancer is 1/10 of what is in the West. Stage-wise distribution, 85% of all cases that are diagnosed in India are stage 3 or 4, whereas in the US, it's 15% of all cases that's stage 3 and 4, whereas in the 85% of the cases are earlier stage patients. Looking at the Globocon data, the Western countries are on the top, while India, the South Central Asia, is at the bottom. The incidence is low, but then the mortality is also proportionately high for the Indian patients. The incidence is 6.3 and almost 50%, the mortality is 3.1. Whereas in US, and the incidence is as high as 83 to 100 and the mortality is only 13. Coming to the Indian guidelines, we have recently had the executive summary published in the latest journal of the Indian Journal of Urology. And it says for Indian patients, the personalized risk stratification should be undertaken for early detection on a case-to-case basis after the age of 50 years. My take-home message from these slides: mass screening with prostate cancer should not be recommended as there's a high risk of overdiagnosis and overtreatment. Opportunistic screening after risk stratification and shared decision-making should be promoted as it reduces mortality. In India, because of the low incidence of prostate cancer, this precludes the use of mass screening, and what we need is increased awareness about this disease, access to healthcare and diagnostic facilities so that we end up detecting these cases early and not in the stage 3 or 4. We should also avoid translation of every screen-detected prostate cancer into overdiagnosis and overtreatment. And last but not the least, the need of the hour is to develop newer screening agents with better sensitivity and specificity, which will help us to predict the lethality of the tumor and help us decide which tumor needs treatment. Thank you very much. This is a review article which we recently published on the newer prostate screening options available beyond the prostate-specific antigen. Thank you.
Thank you, Dr. Tushar. We wanted a little bit more of an Indian data actually on this. You spent a lot of time with the Western data, and I would like Dr. Sanjai Addla to actually comment and chip in for his own publications and studies about health checkups and the screenings and the overall prostate cancer incidence in India.
Okay.
So we wanted a very India-specific discussion today.
If we are going in that direction, so whatever the numbers that we tend to quote, we don't know what is our age-specific PSA for India, so that would be the first one. The second one would be whatever the overtreatment, we are at least a couple of decades away from any of the Western societies with respect to overtreatment. The third one, we are not even doing opportunistic screening currently in India. We are only doing diagnosis when the patient is metastatic, because 70 to 80% of them are in stage 3 and 4 when they're symptomatic with those metastases. So yes, that information about overtreatment is useful, but what do we advise? Let's say if we wanted to give it as a statement and say, how do we screen in India, or do we advise screening in India? Population screening, no. Not because it is not a significant and a problem, just because we don't know what is the appropriate way of treating these patients. So you would screen whenever, like whichever the society that you can take, but probably for India, we would start off at around 50. And then you would start off highlighting the risk of prostate cancer. Because when you look at these Globocon data for 2020, wherever you have got a very good cancer registry, let's take Mumbai, Thiruvananthapuram, Delhi, Pune, the second commonest cancer is prostate cancer. And soon by 2025, the commonest cancer above 65 is going to be prostate cancer. So we need to raise awareness about prostate cancer, that's one. And we need to do opportunistic screening, not case finding when they are symptomatic. So whenever there is a health contact, whether this is in India, the only way the health contact tends to come up is master health checkup or health screening. So anybody above 50 needs to have a PSA included in their health screening so that we can pick up these cancers early. So summary would be prostate cancer is relevant for India. It is going to be more relevant in the near future, those two. And we need to be doing impact above 50, we have to find a way of doing a PSA for these patients. What do we do with that information? How do we end up treating these patients? I think that discussion is for another day, but screening, that's where I would put it. Thank you very much, Tushar.
Thank you, sir.
There's
Thank
small
you, sir.
on screening, which would probably in India help with a stage shift.
Stage shift, yes, dramatically it would help in a stage shift. I always give an example. When we started the robotic program in 2012, 70% of our patients in England, but it was in a socially deprived area, 70% would be T3A and above. Once we had the robot and we started increased patient awareness, within 2 years, it turned around. 30% were locally extensive prostate cancer, 70% were curable cancers. So it is achievable by a concerted effort about case finding in an earlier stage. And that's how we need to find cases in early stages rather than later stages.
Okay, thank you so much.
Sanjay and Ganesh, one more word to add. A lot of people comment, even if you diagnose it early, prostate cancer doesn't kill. Is a very common statement given by many seniors as well as the Western population as well. But our observation, I'm sure the observation of the esteemed crowd here will definitely say that prostate cancer in India seems to be a much more killer disease than what it is observed in the West. So for some reason, our biological behavior seems to be slightly different. So that also have to be kept in mind.
I think somewhere we need to find the data, and the statement that I would make is cancer doesn't kill unless you happen to live in India.
Okay, so we keep that apart. Let's go to the next talk by Dr. Ashwin Tamhankar in bladder cancer. We are done with prostate for the day. Bladder cancer screening, can we ever screen? Ashwin, to you. We cannot hear you, Ashwin.
Sorry. Thank you so much, sir. We are going to cover about the bladder cancer screening. Obviously, all of us know that it's not a very robust modality, but I have tried incorporating few pros for it and few cons for it, obviously. So let's, right. Yeah, so these are the basic principles of a screening. We all know that this is a standardized thing when we would want a screening for a particular cancer. I'm trying to focus only on a cancer or a particular organ. So we know that it should be a important health problem. That is one. So incidence prevalence should be high. There should be a defined treatment for the condition. Facilities of diagnosis and treatment should be available. There should be a good lead time which we should be able to embark upon with the utilization of the screening. That means a latent stage, a fair acceptable short investigation which is cost acceptable as well, with a good sensitivity, not specificity. In screening we are looking at more sensitivity than the specificity. That is an important. It's just a summary of what we learned in preventive social medicine science in third year MBBS, all of us. So and then the agreeable policy making for the final financial things. So bladder cancer, though not the common cancer as prostate cancer in our Uro-onco domain, but approximately a 10th most common cancer in combined both genders, and death-wise about 13th most common cancer. But we all know in the urological cancer, it is one of the lethal cancers beyond kidney and prostate cancer as well. Incidence prevalence wise, again, this is an gross underrepresentation because of the lack of registries and data which we have. Where do India stand in terms of numbers per 100,000 population? Probably 2.2 to 3.7. One TOI article which was published 3 years back was showing 3.1 as the incidence rate per 100,000 population in both genders. If you actually see the data of Asia, which is about the Asia contributes to the maximum incidence wise, prevalence wise, and mortality wise as well, 42% and nearly 36%. So that obviously will have the data coming from India. So there were few papers in the literature which actually tried evaluating the role of screening in bladder, and those are all 2010 literature. Of late there hasn't been any strong literature in last 8-10 years. Probably they tried attempting it and then probably gave up. That is what my gut feeling is after going through the literature. So one paper says that what is the rationale for the screening for bladder cancer? Fairly high incidence and prevalence, though it is not the second most common cancer, but somewhere down the line 8th or 10th most common cancer in both genders. High cancer specific mortality that we know. there is no element of overdiagnosis. What Tushar said, prostate, there is an element of overdiagnosis. There is absolutely no element of overdiagnosis here, because even if you do autopsy studies and find bladder cancers like what they did for prostate cancer, you may not find that many numbers in dead men because of some other reason, I mean to say. So easy and non-invasive access to cancer cells, that is also one important thing. Urine is one medium which you're getting it, so you can utilize that for diagnosis. Majority patients, 75 patients, are diagnosed in non-metastatic phase and they eventually progress. So there is a good lead time. We do not know the data. I tried pulling out this data, that whether, like we say, 4 to 7 millimeters is the average growth rate of a kidney tumor. We do not have similar kind of data for bladder. I tried my best, but we do not have any number to say or the time lag to say. But at least we know 75% are non-muscle invasive at the diagnosis, and those are potentially not curable, potentially early treatable cancers than the because we do not talk about cancer specific survivals in NMIBCs. We talk about cancer specific survivals only once the disease becomes T2 and beyond. So our aim is to try and detect it early, define at-risk population, because we know prostate, again, I'm trying to compare with prostate because as of now, at least we have a robust modality of screening in prostate. But similar to, there is no defined risk population in prostate. It's like all men are supposed to get it probably, or probably at high risk to get it. So unlike that, bladder, we have this defined population of at-risk individuals, of smokers and industrial exposure of chemicals. Pharmacoeconomics wise, a very costly cancer. USA statistics says, in fact, this was presented by Srivathsan from Chennai once, that it is one of the most costliest cancers in NMIBC phase. It saves lives and it saves the cost per years of life saved. So that these are the rationale for screening. Two papers there are 4 papers, in fact, they evaluated the role of screening in bladder cancer. I'm just going to get quick gist of it. So they tried to test microscopic urine analysis cultures, and only if the urine analysis was positive, they sorry, it was a dipstick test, I mean to say, and only if it was positive for trace, they evaluated these individuals for further tests of proper microscopic analysis, cultures, the imaging and the cystoscopies. What they found was these were all men at risk, so they were not general population. So men at risk, 16% picked up hematuria, 8% picked up bladder cancer, quite a big number in at-risk individual. And with the treatment, 80% with that 80% downstaging happening, with only 5% of the screen men getting detected, and compared to 24% of the similar group of Minnesota state registry, wherein they went to muscle invasiveness. So chance of muscle invasiveness is 5% as compared to 24%. And in the long-term follow-up, they hardly any patient died of bladder cancer against to 20% in the general population group. Limitation was obviously a very high positive rate of that dipstick analysis. So these are the newer tests. I'm not going in details of it because these tests, as of now, we all know that they are reserved for surveillance of a proven bladder cancer patient. They are not adapted to that well extent for screening of at-risk individuals. But 2 papers actually looked into these particular segments. And the summary of that is NMP22, though has a decent sensitivity, it is all variable. It goes from 20% to 80%. So sometimes it is a very bad sensitive test as well. So we may not utilize it to a very large extent. We are not concerned about specificity for screening. Again, I'm trying to get the attention on sensitivity parameters. Eurovision and immunocyst, the study shows that immunocyst is generally done on slides sent for cytology. That's a new thing for me. So it gives you 2 opportunities, one as a cytology, one as a immunocyst study, so that you have a better sensitivity. And it clearly says that if you combine immunocyst with cytology, your sensitivity boosts up 95%. So that one test can be looked into as potential marker, but as of now, again, cost effectiveness and other factors may not justify it completely. There was a paper coming from, it's not a proven, they have not published it. It was just a data on SPORE, specialized program for research excellence from MD Anderson, wherein they did the hemastics test, that is the dip check test, and then they went ahead with the cystoscopy and other tests for the patients. I could not get the final data out of this, so there is a limitation on this. 2 papers, Blue P project, and which concluded that these particular screening tests, it needs further research for evaluation. It's a 2010 publication. Like I said, these publications take us back to at least 10 years. There is nothing in the recent literature. Another paper of at-risk individuals. So these are all men working in the carcinogenic aromatic amine factories. NMP22 has been explored for screening them. It also says that it is affected by level of hematuria, infection, and a level of concentrated parameters in the urine. So they tested urine creatinine ratios, thereby mentioning that it is not recommended as a primary screening tool in high-risk population, nor as an alternative to cystoscopy in follow-up. Today, we are thinking about only screening, so I'm not going to the surveillance parameters. But again, NMP22 may not be the ideal most test for the screening of at-risk individuals. So what we can assimilate out of this and try and think over it for next subsequent years to consolidate on this is at-risk, high-risk screening should be done. Unlike a standard generalized screening done for all men from prostate, it should be an at-risk individual screening. Generally, they are embarking upon at-risk screening for head and neck cancers these days. Those all, especially in India, tobacco chewers, they are thinking of having quick oral examination and test for those individuals. Similarly, we can adapt this for our bladder cancers, because we know 50% are smokers and nearly 30%, this is a European statistic, nearly 20% of adults of Europe are smokers. And cessation of smoking does not put them back to normal risk immediately. It never comes back to normal, but it goes to more than 60% reduction after 25 years. So any smoker who has smoked good amount of pack years should be the one who should be included, and those industrial exposure individuals. And possible element will be genetic analysis and genetic test. And we should embark upon primary prevention, that is educating people for minimization of or cut down of those risk factors. 2-3 slides last, which will tell us about microscopic hematuria workup. Again, one important thing which we all miss out in urine analysis report, if the patient has smoking history and there are RBCs, it should help me to connect a link and keep that patient in the regular follow-up. Explain to him that you have a microscopic hematuria. Please be on a diligent follow-up for any other reason you have presented to me, but this is one important parameter which you should be looking into. So at-risk individuals are all men, age-wise higher age, smokers, previous microscopic hematuria or any history of gross hematuria, irritative LUTs, previous radiation, cytotoxic chemotherapy, and indwelling foreign body. So these are the at-risk individuals. A good history is to be taken. We stratify those based on AUA into low and intermediate and high. So again, I will embark upon high-risk individuals with microscopic hematuria. What the guidelines say is, for high-risk individuals, do a cystoscopy and CT. And for intermediate and low risk, they ask us to repeat it. And intermediate, they ask for a sonography and a cystoscopy. So again, microscopic hematuria is one important thing. It is not described now. It is all described way back in Hippocrates' time. I'm not going in details for the want of time. A simple urine dipstick test for a patient who is a regular smoker will possibly give us some estimation on the level of microscopic hematuria. Coming back to that slide of high risk, more than 25 RBCs per high power field takes us to an high risk classification on AUA. So we can correlate that on dipstick of more than 4 units positivity. So without infection, a dipstick of 4+ probably gives me rings a bell in my mind about that patient for keeping him in follow-up. Last one slide or 2 slides on screening. So we all know Tushar presented the number of NNT and number needed to screen of numbers coming down as we increase on the follow-up for ERSPC, coming to 570 and 18 in recent 16 years follow-up for ERSPC. We do not have those robust numbers for bladder. Similar numbers are there for breast. We do not have those numbers for bladder, but current guidelines are against it. This is USF as in that task force recommendation presented in 2010. It shows negative recommendation of bladder cancer. This is EAU. It again says routine screening for bladder cancer is not recommended. My last slide. What we probably should be doing is screening is an important aspect. Probably we should be embarking on high risk screening. Primary prevention is important. So smoking cessation, sensitization of people about what Dr. Ragavan said, that hematuria should not be neglected. So sensitization of people about primary prevention and secondary prevention, which is early detection, should be done. Smoking screening on, or it should be organ specific. We should not probably think only of bladder because we are uro-oncologists. If we collaborate with, say, lung team or the head and neck team as a part of oncology division, there is a lot to work on screening for smokers. A smoker individual can be screened for many things together, not to justify only for bladder, maybe I will say. And hematuria evaluations and clinics are the another parameters to sensitize people. Newer tests and cost implications obviously are miles to go for justification, honestly. That's it. I will conclude here.
So thank you, Ashwin, for this bladder cancer. Can we ever screen? I think the presentation was put in the right perspective. Bladder cancer is a very difficult disease. There are multiple factors actually where we look at origin of bladder cancer. I mean, the risk factors rather, age, occupation. Maybe as the time goes, we might even detect patients. Like I have 2 patients who are FGFR3 positive now, and actually these 2 are NMIBCs just because they could afford the tests. they went, did, and now it's positive. So screening, we don't know whether, like Ashwin said, there can be some catch in the master health checkups at certain hospitals where we could, get these things and then put these people to specially screen for bladder cancers. But as far as the one of the slides showed, the recommendation is against. I think since our meeting topic had awareness also, currently probably we should still harp on putting awareness about bladder cancers or early bladder cancers rather, which are quite treatable, as Ashwin said, into people like us, urologists or even nephrologists who would look into hematuria. So I guess these are my comments, and I invite the next speaker, Dr. Mahendra Pal, who is a professor of uro-oncology at Tata Memorial Hospital, for the next talk, decreasing incidence of penile cancer in India.
Can I just make a comment, Ganesh?
Yes,
Sorry,
please.
on the bladder cancer one.
Yes.
So we used to have screening for bladder cancer in England for non-visible hematuria. The pickup rate is almost 3 to 4%. So you end up over investigating 97%, and the number of referrals you get was huge for the outcome that we were getting.
Absolutely.
And almost all these patients will end up having visible hematuria. So for India, I think what would work is the awareness, saying that the first time you have any blood in the urine, please go and get investigated,
and
rather
maybe,
than going for the microscopic one.
maybe we can put awareness in the doctors also, because uro-oncologists, it sometimes it gets overlooked, and India has a very common problem about stone disease.
Yeah.
So I would rather see a patient lesser than 60 with stone disease and hematuria rather than malignancy. But sometimes the times are changing now. So going to Mahendra, please. Welcome, Mahendra.
Yeah, thank you, sir, and thank you, you and Ragavan, sir, for inviting me for the talk. So my slides are visible and I'm audible.
Yes, Mahendra, everything is visible.
Yeah.
Yes.
So this topic talk is the decreasing incidence of penile cancer in India. Have we made the change? So let us have a incidence in the worldwide at present. So globally in Western world, penile cancer is uncommon and incidence rate is around 1 to 2%. And in USA, the penile cancer is also affected by the race and ethnicity, and his white Hispanics has 1.01, Native American Indians has 0.77, and African American and white non-Hispanics has 0.62 to 0.51 incidence rate. And again in USA, if we see that the age-associated incidence rate is decreased from 0.84 per lakh in 1970 to 2.58 up to 2002, and in Europe it is overall stable till 2013, and however it is increasing observed in Denmark and the UK, 21% between the 30 years of gap, and in South America, South Asia, and part of Africa, the incidence account for 1 or 2% of the male disease of the male malignancy. And India, it is 0.7 to 3 and 8.3 in Brazil, and in Uganda, it has this is the most common diagnosed cancer in the male. So we can see the incidence is very in different part of the world. And the most common age presentation worldwide is between 50 to 70 years of age, and in USA, the median age is 68 years, and with the increasing age, the risk of penile cancer also increases if the patient male is more than 50 years. So if you can see the Globacon, however, Globacon that penile cancer is the last 4 cancers all over the world, and but if you see the India is one of the country where the maximum incidence of penile cancer is there. When we compare the incidence, mortality, and the 5-year prevalence rate, the Asia comprises more than 50 to 60% of the cases of penile cancer all over the world. And again, this review article published in 2012, and on that time, it highlighted that the India has the highest incidence of penile cancer in the world in that time, and we can see even we can see in this chart pictures. So now coming to incidence in India. So I was lucky. I found a paper of a master published in 1967. Maybe Jan Kulkarni sir will remember this paper. He must have this thing quoted to so many papers like that. So in 1967 also, if we see the Bombay was the representing the country, and in that time penile cancer was the most common cancer in India. And if you see the city-wise, the Madras was the leading city which having the penile cancer. Coming to the religion-wise, the Hindu, Christians, and Parsis has the maximum number. Muslims has the minimum number of penile cancer. And again, circumcision was the important factor having penile cancer. The patients uncircumcised, they have more. They are having cancers. Again, we studied the 1992, which is the basically done for the pathological tissue diagnosis base, and they found that penile cancer was there on that time up to 43%, more than prostatic cancer. Maybe it is a regional bias thing, but it is there in the literature. In 1912, we have a paper which again showed that incidence is more common, the patient having more than 50 years of age, more common in Hindu and who were uncircumcised. And they proposed that there should be a national awareness campaign should be against the prostatic cancer. Another study in 2014 that also showed that after the prostatic cancer, the penile cancer is the most common cancer to 11.6 per lakh, and with the increasing age, this incidence actually maybe becomes 3 to 4 times between 45 to 65 years of age. And if we see the surgically, so penile cancer surgery was performed maximum number compared to other cancer in that time. Under the study of the 50 cases, again they showed that the age group is same, 31 to 60, and there's a delay in diagnosis of 1 to 6 months, and this due to the following reason, that the most patients are from the rural area. They have labor and farmers, and they have difficulty in reaching to the health facilities, and again getting the qualified doctor affect their daily wage earning and financial burden. And there is also there's a social stigma and mistaken belief that it is also it is healed by itself. Another study from the it also showed that carcinoma is more common in elderly or circumcised Hindu and smokers, and the patient having and most common present symptoms were ulcerative growth in the glands and the phimosis that. From Jharkhand, again the similar study result, we found that old age reason is Hindu, rural area, and the patient having phimosis have a more incidence of renal cancer. The fear, ignorance, and embarrassment, these three are the important feature which led to the high this advanced level of the disease and during presentation. The average age was 60 years, and 80% patient have a penile lesion, and most common lesion was the glans and shaft, and 60% of the patient having history of smoking, and 100% did not have circumcision. This is study from the Bihar. This is the data from the Tata Hospital, where we see there is a increased incidence from around 12 to 16. Then is a decrease trend towards 17 to again 19. It increase. Maybe it's a tertiary care center. That's why we are getting more cancer patient year by year because of maybe lockdown. In 1920, there is a sudden decrease in the cancer, but we see the disease burden. So if we see the modified Ginil dissection, we are performing, these numbers are increasing, that we are getting more N0 grind. And if you see the surgery wise, pachypenectomy is performed maximum in the number of the patient, that again we are getting a localized disease, not the advanced disease. If we see the worldwide, so we are happy that in prostatic cancer, bladder cancer, renal cancer, we are far behind in the Western world. But unfortunately, in the penile cancer, we are ahead of the world by the just double in number. So this is the data from India in 2000. Recently, data is there, where the incidence rate is 1.6 and mortality rate is 0.7 in all in India at present. And if we see the data, this data is in 2014, where in Chennai and Mumbai, we can see that Chennai has a incidence reduced from 2.3 to 1.2, and in Mumbai it was 1.3 to 1.8, but has a increasing trend in 2014. And latest if you see the Mumbai is also showing decreased trend in incidence. So now it is to 0.7, and Chennai 3.2 to 1.1. So definitely there is a decrease in incidence of the penile cancer in India, but due to large denominator, we are having the maximum number of the patient in the world. This is the perspective published in 2021. This is the Global Society of the Rare GU Tumors, and specifically India, they have one paragraph, and they mention penile cancer in 2020 is the highest crude number of prevalent cases in the penile cancer. And this number has increased over the previous 4 years, despite of diagnostic delay caused by the global pandemic. And they specifically, they mentioned these line, the treatment of penile cancer in India not centralized in referral center, but mainly managed at the local center. Management of penile cancer is not always uniform across center as far diagnostic and surgical management is concerned. And the most important, it is in managing the clinically negative lymph node, which generally ignored in the peripheral and the local center, and which could be benefit most from the new technique like DSNB, which is mostly used in the high volume centers. And in India, the last, which is most important, one of the most important factor is India has a lack of population-based registries and no recruiting RCTs available countrywide. If in this article, there are only few studies are there, but if you say the large randomized RCT and large study, multi-study studies, it is not, India is not in that list. So what challenges in the India? So we have challenges in India: lack of centralization, referral system, penile surgery considered simple procedure at periphery and notes generally ignored because some ignorance among the physician or the no updating of the knowledge and lack of data. What about the patient related? It is the most important is the unawareness, social stigma, economic status, and sometimes remote area reaching the hospital is also an issue for many patients. So can India contribute significantly in global penile cancer research? I think yes, because we have a large number of patients having great incidence and high volume centers of excellence at present, which is not before, maybe 10 to 20 years back. And if somebody wants to do that, he has to choose the area of his interest and start contributing in the management of the penile cancer, whether it's the research or the managing or spreading the awareness of the penile cancer. So the change we need, I recently, Dr. Gagan Prakash from Tata Hospital, he published one editorial, adding the name of Atmanirbhar. So I would like to put this Atmanirbhar and what we should change in Atmanirbhar in penile cancer is we should be Atmanirbhar, like with Indian Urological, Surgical and Oncology community with respect to penile cancer research and the management. We should become Atmanirbhar, that we can lead the way in generating evidence of this common cancer in India, but not common in the world. We should be Atmanirbhar in defining techniques of DSNB and templates and boundaries of dissection. And we again should be Atmanirbhar in construction or validation of the tool to gather quality of life information with respect to urinary sexual function in penile reconstruction and the need exploration. That because we can do that, and we should do that. And for that, what we need awareness among the patient and among the treating doctors and centralization of the healthcare system. That all must be considered to make the change. This is my last slide. Thank you.
Thank you so much, Mahendra. And I invite Dr. Ginil, professor at Amrita, for his comments and additions. Welcome.
Thank you, Ganesh. Mahendra had an excellent overview of carcinoma of penis. Few of the points I want to highlight is carcinoma of penis. Even though we have a lot of advancement even now, we are having almost double the incidence compared to the world. We know that from the data which is presented by Mahendra, the incidence is probably reducing, but we have made a lot of advancement like the hygiene, awareness, all these things. We have made a lot of advancement. Still, why we are persisting at this high level? Probably there are a lot of factors we have to consider, we have to evaluate. There should be a centralized mechanism to evaluate that. Probably we have got more involved. We have to involve more in the name of SOGO or government institutions or academic institutions, because we don't know exactly why the high incidence. Is it purely because of socioeconomic issues? Is it because of the high incidence of HPV virus incidence in the community, or is it because of the high incidence of probably multiple sexual partners? We are not knowing about this thing. We don't know a lot of factors, because of which probably the carcinoma is penis is higher, and where we have to actually strike. So apart from the incidence, we have to evaluate these factors, then only we may be able to come out with a change. And probably that is where we have to look into we have to go hand in hand to detect all these factors, evaluate all these factors, and then only we will be able to probably change the scenario. And there is a lot of interaction is required between the higher institutes where the volume. Another point I want to highlight is myself in Kerala rarely see a carcinoma of penis, but we see that just across the border in Tamil Nadu there is a high incidence. Is it purely because of the local factors? There is something beyond that, I feel. So just these are the comments I want to make. A lot of studies are required where is a huge opportunity for we Indians to come out with some measures to reduce and know about this rare entity. Thank you.
Thank you so much, Ginil. Invite the next speaker, Dr. Srivathsan. Yeah, you can. Renal cancer, changing patterns at diagnosis. Go on, please.
Thank you, sir. So the topic for today is renal cancer changing patterns at diagnosis. Has screening radiological made a difference? I think from the depth of the heart, we all know that radiological screening has made a lot of difference to our early diagnosis of renal cancer. And we have come across so many patients who have been diagnosed by asymptomatically with a renal tumor just because they have underwent an ultrasound or a CT for something else. Personally, I have seen a lot of patients being picked up during the COVID era where the CT covered the upper part of the abdomen and incidentally diagnosed and picked up a renal tumor on the upper pole and so forth. Including a senior nephrologist in Chennai. So all this, does it practically make us feel that, should the RCC be screened? And that's the topic for today. So going on to that, we all know that the RCC has a rising incidence and increased issues that we are facing currently. After 3 decades, there has been a great interest, not only in India, but also internationally, and with obviously a lot of robotics and everything coming into play earlier, early stage cancers is what we are looking at. A study on early detection and treatment of RCC was recently defined as one of the top research priorities by kidney cancer patients, caregivers, and expert clinicians in 2 independent studies, which is quite surprising because we hardly speak about screening when we talk about renal tumors. Incidentally, during research for this talk, I also found out that the Eastern Europe has the highest incidence of renal cancer, Czechoslovakia being the highest the country with the highest incidence of RCC, probably due to chemical as well as long history of smoking as well. They did find out in the Eastern Europe that the greater average number of years of life lost, which is basically a measure of cancer burden dependent on patient age at death and the number of deaths at each age. This is more than even colorectal and prostate cancer as well. So aggressive disease is what we already know. Coming on to this, I based my talk on this beautiful paper by Dr. Rossi. Rossi has written a lot on screening and epidemiology of renal cancer. Would request you all to go through that from NHS. So they did say that this is an insidious tumor. We all know it is called the internist tumor and the physician's tumor because usually it is asymptomatic unless it infiltrates into the pelvic alveolar system or causes metastasis and so forth. But it does approximately 2% of global cancer diagnosis and death, and it is supposed to increase. It is the deadliest of the urological neoplasm and has a dismal late-stage 5-year survival rate of 12%. Which is like really poor. RCC is now the 7th most common form of neoplasm in the developed world. The SEER data showed about 74,000 new cases every year in 2019, accounting for 4.2% of all cancer. 1975, it was 7.1 in the incidence per 1 lakh. Now it has grown on to 2016, 14.9 per 1 lakh population. Now, this is one of the fastest, I would say, incident tumor, whether it is biased because of pickups due to more radiological investigation is something to be noted. However, since it has peaked at 16 per 1 lakh incidence in 2008, it is steadily plateaued and it has not increased given the fact that our radiology has improved in the last 2 decades as well. Now, we all know the risk factors associated with RCC. Why I'm doing this slide is because any screening program should be targeted, especially with a low incidence like this, not as common as the breast cancer like all the others have spoken. So should have a risk-directed screening protocol as well. So these are all the risk factors that is associated, the most commonly being the cigarette smoking and the obesity, and the rest being exposure to the chemicals and the genetic hereditary syndromes as well. So these are all the positive associations that we are very commonly known. Male gender, age, obesity, smoking, hypertension, renal disease, especially, these are very good candidates for screening for RCC. But even in occupational exposure and analgesic abuse, which is quite common in the developed countries as well. When you look at the kidney cancer 5-year net survival and incidence by the stage, as I told, it's a very aggressive tumor in the sense the survival rate is really poor in spite of treatment, and it was so even if you leave it without the treatment as well. So this is the UK data followed up to 2018. You can see the various number of cases in stage 1, 2, 3, and 4. As expected, the stage 1 trumps all with 17,708 cases, and you do see a drastic drop in the 5-year net survival rate, starting from 88.2 in stage 1, dropping down to 13.2 in stage 4, which is quite expected. Stage 4 generally do not last, in spite of all the treatments, more than 1 year of this thing on average. So this is a paper in the EAU with the recently in 2019. So this is the international variations and trends in the RCC incidence and mortality. It does speak about the Indian incidence as well. In Asian women, significant increases has been observed in India. Usually it's more common in the men, but they have found an increase in the Indian women as well, especially the data from the registries from Chennai and Mumbai. The mortality trends, however, have been very stable, with declines apparent only in Israel and Japan, whereas the rest of the world are matched neck to neck. Now, the study of the RCC confirms that it requires a continued surveillance and analysis of patterns and trends and incidents in order to given the synergy between the various indicators. Now, to disentangle the effects of smoking and obesity is difficult, and this is the target population that it has to be directed towards. Also, there is a lot of difference in the type of treatment that is offered to the patient on diagnosis, especially the Western world offers more minimally invasive, more nephron sparing approach to somewhere there may be not offering a nephron sparing approach due to lack of expertise and so many other factors as well. The long-term best practice approach would be primary prevention, which is slightly difficult in RCC. We know only 2 risk factors, and those are really difficult to control as well as with any other cancer like lung and so forth. So this is the Globocon 2020 data. I'm quoting those as well. You can see the kidney showing about 4.3 lakh with almost 1.79 mortality and so forth. The incidence has been pretty steady, and it's more common in the Western this thing, but we are slowly reaching. Asia slowly has become the #1 leader in RCCs as well. Now, this is one paper that I could find, though albeit it's a slightly older paper from All India Institute of Medical Sciences, which tells us the trend over the previous decades, which has happened over, I think, under the term of Professor N.P. Gupta as well. Now, they had done an extensive retrospective look into their epidemiology from 1988 to 2007. They have divided it into 4 cohorts, dividing into 5 years of each decade. And you see the number of patients that were diagnosed starting from 103 to slowly increasing to 304 patients that they have taken. I agree this is not a population data. This is the patient data that has approached the institute, but still this would give us an idea about how it has evolved over the decades as well. So 17.63% of these patients were benign, while the rest most commonly were malignant. Now, if you see the age of diagnosis over the cohort, starting from cohort 1 to 4, it has slowly decreased to the age from the 7th decade to the 5th decade. Now, this is a very significant. There could be, there could be a bias because we are diagnosing it earlier, but still there has been a continuous decrease in the age at presentation and age of diagnosis as well. Incidentomas have increased from 11, that is 10% to in cohort 1 to almost 27.6% in cohort 4. We are diagnosing more and more grade 1 and grade 2 tumors according to the Furman grading of the previous era. So we are diagnosing more and more lower grade tumors as well. Now, coming on to the current evidence on screening for this thing, should we move on to a trial to decide whether RCC is worth doing the screening program as well, especially in a very economically constrained country like India? Now, we estimate that we would need to see around 300 deaths from a RCC across a control and a screening group to have a 80% power to demonstrate a 25% reduction in the death rate from RCC if you do the screening over a 5-year period. Now, this is complex mathematics. People will tell you this is the value that they put to a certain disease and number to detect, and what Ashwin and Aditya has spoken about. Now, this is very important for us to decide whether a test is worth it, to disease is worth screening or not. Even if you have this and number, you should also have a test to do that as well. That is what I'm going to talk about later. Now, even with a risk-based strategy, including only 60 to 70-year-olds, smoker or ex-smokers, for example, we would require 1.75 lakh participants in both the arms in order to arrive at a conclusion whether it is viable or not. Given the large number for a definitive day, a number of outstanding research priority has to be taken into account before even we can suggest a screening program for this thing. Now, what are the costs associated with this? So you can see this is again from the same paper. You can see the cost that is associated with each and every incremental test and everything. So you should also understand that screening will be followed by the test in order to prove the diagnosis, which will involve a huge number of machineries, including CTs, radiologists, biopsy guys, interventional radiologists, urologists, and so many other factors have to be countered into the cost in order for us to understand what is the real cost of screening program. Is it really worth it or not? Now, if you go on to the research priorities in screening RCC, these are the major points that we need to look into before you even suggest one. Developing and validating accurate risk prediction models for RCC. We don't have that yet. Developing non-invasive methods of finding early cancer in kidney. We do have a certain bit of that. Establishing optimal screening modality and target population. We know a little bit about RCC risk population, but not fully. Based on the above 3 points, you have to design and implement a screening program, which has to be establish the feasibility, the public acceptability, and the potential uptake of RCC screening. Establishing the prevalence of RCC and the stage distribution of the screen detected RCC, and evaluating the potential harms of screening, including the effect of quality of life, overdiagnosis, and overtreatment. We can safely say when compared to prostate, overdiagnosis and overtreatment, it generally doesn't occur with RCC as well as with bladder. Now, this is the Wilson-Jungner criteria that we apply to any screening program. Ashwin just spoke about it while comparing it to the bladder. This is for the RCC. How do we apply it to the RCC screening? The condition should be an important health problem. Definitely, it is an important health problem. Accepted treatment should be there for the accepted. We do have a lot of minimally invasive nephron sparing treatment, definite advantage in treating early cancers and so forth. There should be a recognizable latent or early symptomatic stage. Now, this is very, very valid when it comes to RCC. We all know the growth rate of RCC, of at least most of the RCC. So you get a valid lead point which you can utilize it to diagnose it before it starts spreading or it starts breaking into upstaging and so forth. There should be a suitable test of examination. Now, this is where we are all stuck. So I'm going to speak about the test in the later part of the talk. The test should be acceptable for population, yes. And the natural history of the condition, including development from latent to declared kidney, should be adequately understood. Now, again, we have a problem here because we do not know the actual natural progression of RCC with regards to how the molecular level things happens when it becomes a metastatic disease as well. So coming on to the next thing, do we have a biomarker for now to use as a screening modality? Sadly, we do have a couple of biomarkers, but sadly, I can't say that these are very good enough for it to put into population studies. The first one is the aquaporin 1 and the perilipin 2. The sensitivity is about 85 to 92% and specificity of 87 to 100%, which is very good. However, these are markers of clear cell and papillary and misses out on other variants of RCC. There is also another composite 3-marker assay based on NNMT, L-plastin 1 and non-metastatic 1 protein NM23A. Now, this has a 90% sensitivity and 95.7% specificity, and this is also seems to be very good. All this have to be tested out before it can be put into practice. There is a third one called as a urinary KIM1, which is also significantly higher. All this are yet to be put into practice. Now, before I go on to ultrasound, can tomography be used as a screening modality? I know that this as a screening tool will be considered as very too much, and renal lesions are, though they are the commonest extracolonic malignancy noted in colonography, however, it is not economically viable, and radiation as well. From a standpoint point of view of a screening program, I think ultrasound will be the potential option because it is like completely visualize the kidney in 97.4%. For all this data, the correlatable data is abdominal aortic aneurysm screening they started doing in the 90s, 80s, and 90s, where they wanted to screen everybody for aortic aneurysms. And this is what we have to correlate with. So it is very good when compared to that. It's almost equivalent. Ultrasound has excellent sensitivity and specificity for detecting RCC. It's non-invasive, safe, radiation-free, quick, and everything, positive factors. But there are also certain negatives. Obesity is a big disadvantage in ultrasound, and that these patients are mostly obese as well. So it just brings down the sensitivity as well. For every 5-unit increase in BMI, the risk of RCC increases by 24% in men and 33% in female. Second, accuracy is dependent on the lesion size. So if the smaller the RCC, the worse ultrasound is a modality to screen. So this is also has to be taken into account while suggesting ultrasound. Renal ultrasound cannot be trained on to a non-medical practitioner to put on into the field as well. So it has to be done by an expert. An expert ultrasound, as you all know, is completely different from a novice ultrasound. And CT is finally always needed to confirm. Because of all these reasons, there are some negative factors associated with ultrasound as well. Now, these are all the various screening in national health scheme programs, both in Japan, Canada, and Germany, USA, and everything. Every study has proven, and these are all not small numbers, they are good lakh numbers, and they have all proved that there is a good efficacy of doing it up to 100%, 98.4%, and so forth in doing an ultrasonic screening. So can we use MRI as a screening? You can't. I mean, it is used only for differentiation of a small renal mass, but I don't think it's going to come in the near future. When I'm not talking about CT as a screening modality, it's not going to come as well. Will AI change things? I think AI would change things because maybe if, for example, an ultrasound or CT is done by a technician, it is uploaded and the AI would screen it for possible renal tumors. I think that's going to be the future. When it is going to come, I'm not sure, but it may change the dynamics in the future. So these are the research gaps that are associated with RCC screening. I think we need to find a test or a tool which is going to be effective as well. So whether the rate of RCC detection has increased, that is a definite given. I don't think we need to have papers or data on it to, in order to define that as well. However, we should always understand that any screening program.
Sir, your time is up.
Oh, okay, sir. That's my last slide, sir.
Public
awareness is what is more important. So the take-home messages is that the incidence is increasing. Asymptomatic individuals had diagnosis, but it has a high mortality rate. So it's good for a screening, this thing. It does meet a few criteria for a screening. However, targeted screening of high-risk individuals is what the way to go forward. Thank you, sir.
Thank you so much. So renal cancer, changing patterns and diagnosis, as he said, we do see changing patterns, increasing incidence, and maybe younger age. We had a publication done in 2017 from Tata Memorial Hospital, where we had published 2013 whole year data. So we had got about 24% of our patients presenting below 50 years of age. And today probably that percentage has gone up. Again, to say specifically, T1 plus T2 was 32% in that publication, T1 plus T2, clinical T1, T2. So that has, again, probably in practice looks like gone up, and probably I put that reason for the change to slight awareness, maybe visiting the hospitals, health checkups, as well as the imaging which goes with vague abdominal pain and detection of incidental small renal masses. I actually also would invite Dr. Ragavan to give his comments because Dr. Yuvaraja is not joined properly.
Thanks, Ganesh. Sri, for a fantastic presentation. Sri, quite in detail. And as you said, there are some, the Wilson-Jigner's criteria, some of them may not be applicable for renal cancer, but some of them are so applicable for it. For example, the screening test of an ultrasound scan has an extremely high sensitivity and specificity, and the treatment has an potential effective cure. So should we screen for renal cancer? My answer is yes, it is not a major health problem as a cervical cancer and breast cancer is, but the screening tool is very easy. So, and the cure rate of early detection is very high. So my view on the matter is that it is if people are willing to assess themselves for this, it's nothing wrong. At least raising an awareness that such a cancer exists and a potential treatment is possible for them itself is a good step forward. And as Ganesh said, we are seeing a huge tectonic shift in the incidence of small renal masses compared to what we used to see in 2000 and 2001 and 2. Almost the majority of the cases we see are small renal masses compared to the large masses that we used to see in the past. So there is a shift to left which is happening. Whether it really translates to survival, and it's also observed that the patient who had small renal masses and treated, as you know, between our center itself, the majority of the small renal masses survive very nicely, or surviving very nicely. So perhaps it is a disease which has a great cure component and a very good screening tool, but it is probably not high in terms of incidence to make it a public, government-driven public exercise of screening. So with that word, I will close it and allow Amitabh to take over from there. Ganesh?
Yeah, so a small thing in addition, like most health checkups today do have sonography as a component, and so that we can get these renal masses. And also India is sitting on a big population of, say, hypertension and diabetes. So when they go to their physicians and nephrologists, they do undergo a screening sonography. So probably these things might help us. This was just a add-on comment. So welcome Dr. Amitabh Singh for testicular self-examination, genetics and screening for testicular cancer. Amitabh is a consultant in GCI Delhi.
Good evening, sir. Thank you, sir. Thanks for introduction. So actually, I'm the last batsman of the inning, so everyone must be watching at the clock. But I have been given extra responsibility to present the genetics of the testicular tumor. So just I will take extra time of just 5 minutes. Just bear with me. So the topic of discussions for today talk is genetics, incidence of testicular tumor in India. What are the benefits and harms of the screening for testicular tumor, and what are the strategies for the future? So regarding the genetics of testicular tumors, so it has got some peculiar things, like it has got very strong hereditary history. So any person who is having a history of or affected brother might have almost 8 to 13 times of higher incidence of testicular tumor, where if he is having a positive history in his father, then he can have almost 3 times higher incidence of testicular tumor in the future. All the seminomas, they resembles the primordial germ cells, whereas non-seminomatous germ cells, they could be undifferentiated in form of embryonal carcinoma, and these embryonal carcinoma, they look like primordial germ cells, whereas these non-seminomatous germ cells, they could be differentiated also, and these differentiation happens from the embryonal carcinoma in form of teratoma, yolk sac, or choriocarcinoma. And almost every testicular germ cell tumor happens from or arises from intratubular germ cell neoplasia. So the whole this pathogenesis or the genetics of testicular tumor evolves around the polygenetic susceptibility. So unfortunately, there is not a single gene which is responsible for the pathogenesis, which we can target for the therapy, or which like we can use for the screening or the follow-up purpose. So it is basically a polygenetic susceptibility. Along with the polygenetic susceptibility, there could be a chromosomal abnormality also in the form of multiploidy, hyperploidy, and isochrome 1215 is almost a hallmark of the invasive testicular tumor, and it can be present in almost 80% of the testicular tumor. Apart from this, there could be pluripotency markers abnormality also, genetic abnormality also, which just stops the differentiation of these primordial germ cells, and these cells, they retain the pluripotency. That's why these seminoma and this embryonal carcinoma, they de-differentiate into another types of non-seminomatous germ cells like choriocarcinoma or this teratoma or yolk sac tumor. So apart from these genetics, there are other environmental factors also which plays very significant role by altering the DNA damage repair mechanism or modulating the epigenetic reprogramming. So it is a basically polygenetic and multi-stage basically evaluation. So all these genetic mutation, they happens during the embryonic life into the embryonal germ cell, primordial germ cell. And ultimately, after this first wave of the genetic events, they go into the dormant phase. And ultimately, when these patients, they become adult under the influence of hormonal surge, the second wave of the genetic events happens, and these cells, they differentiate into the tumor cells by abnormal or mutation, like by upregulation of the pro-onco genes or by the suppression of the tumor suppressor genes. So apart from the genetic abnormality, there are various chromosomal abnormality, as in seminoma or intratumoral germ cell neoplasia. Mostly we found hypertriploidy. So triploidy, that means 3N, that means this 23 into 3. So there could be more than chromosome 23, whereas in non-seminomatous germ cells, there could be hypotriploidy. That means the chromosome number would be less than 3N. So it is very interesting to note that the mutation burden in testicular tumor is very less compared to the kidney and bladder. So it is almost roughly around 0.5 mutations per megabase in testicular tumors, whereas in kidney and bladders, it could be almost roughly around 8 to 11 mutations per megabase. And as I have already mentioned, that gain of 12p is hallmark. It is almost found in 80% of the patient, and it is a hallmark of the invasive tumor, because almost all these tumors, they appear or they originate from the intratumoral germ cell, where these gain of 12p is not noted. So when there is a gain of 12p, that means isochrome 12p, it affect the KRAS gene, which is basically responsible for the pluripotency. So what happens by the this mutation in KRAS gene, the potential of the dedifferentiation or maturation of these primordial germ cell, it stops, and these cells, they retain the pluripotency in their lifetime actually. So we can also find the increased copy of 7, 8, 17 or X chromosome, whereas we can find a decreased copy of 4, 11, 13 or 18 chromosome. We can also have a single gene mutation also in testicular tumors in form of KIT mutation, which is basically tyrosine kinase, which is responsible for the testicular development. We can have a mutation in KRAS or NRAS gene, which ultimately activates the PI3K AKT pathway, which is responsible for the cell maturation and various protein synthesis for the cell survival. We can have a mutation in BRAF gene also. We can have a mutation of TP53 gene, which is ultimately responsible for the cisplatin resistance. So what happens if the T53 is normal, then after giving the cisplatin, T53 sense that there is a DNA damage and it induces the apoptosis in the affected cells. Whereas if there is alteration or mutation in T53 gene, it doesn't sense actually that the cell is abnormal or if there is a DNA damage. So it just escapes the mechanism and it survives somehow. So that's how it's just induced the cisplatin resistance even after getting the chemotherapy. So this study was published in the European focus. So they author studied the genomic characterization in the chemotherapy resistant patient in seminoma and seminoma also. And they found the various mutation in RAS-RAF pathway, T53 pathway, cell cycle pathway, RTK, PI3K pathway, DDR mutation pathway. All the frequency of the mutation are different in the seminoma or non-seminoma, but it is very interesting to note that the tumor mutation burden was very less in the seminoma, where it could be high in the seminoma, non-seminomatous germ cell also, and there could be MSI high possibility in the non-seminomatous germ cell also. So this just opened the opportunity to give immune checkpoint inhibitors in few cases of the non-seminomatous, not in all cases. Whereas in seminoma and non-seminoma, even in chemotherapy resistance patient, we can have a genome sequencing just to see what is the main pathway, what is the main driver pathway in form of RAS pathway, T53 pathway or other pathways. So we can have a targeted therapy for all these patients. Just like they have mentioned this patient who had seminoma and he was given TIP 4 cycles, but he failed. So immune checkpoint inhibitors was given, but disease didn't respond. He had a fulminant metastasis in form of the lymph node in the retroperitoneum, mediastinum. So this patient was basically submitted for the genome sequencing, and he was found to have a KRAS amplification. So ultimately, this patient was given everolimus, and he had a very significant response. Or in the PET scan, you can see with the blue arrow. So they found a very significant decrease in the SUV after giving the everolimus to this patient. So we can use this opportunity in form of genetic study. So by that, we can have a targeted therapy even in cisplatin resistant patient. So we can use the genetic study just to have a tumor markers in form of IHC also to differentiate various like seminoma, embryonal carcinoma from the tubular germ cell neoplasia. Because these seminoma and embryonal carcinoma, they express the OCT4, whereas the embryonal carcinoma don't express the CKT. So what happens actually, these genes, they are responsible for the pluripotency. So as these cells, they keep on maturing there along with their pathway, so they tend to lose all these genetic IHC expression of all these genes. So you can say very like in embryonal and seminoma, all these cells, they are positive for the OCT4 or CKIT, whereas in teratoma and yolk sac or choriocarcinoma, all these cells they are negative for the OCT4 and CKIT or SOX, this sex determining region 2. So we can use all these genetic genes in form of IHC to differentiate all these cells from the seminoma or embryonal cell carcinoma. Coming to the epigenetic markers in form of the messenger RNA, which are circulating in the blood. So the messenger RNA 371 to 373P and messenger RNA 302 to 367, they were mostly studied. And it has been found that the sensitivity and specificity of 371A and 3P was in toto higher than the combination of the conventional tumor marker in form alpha beta protein, beta SCG or LDH. And it is very interesting to note that even seminoma express all these markers in almost 85% of the patient. And these markers, they correlate very well with their clinical stage and the tumor bulk in the body. In another study, it has been found that messenger RNA, microRNA 371A or 3P has almost 90% of sensitivity, 94% of specificity, whereas 97% of the positive predictive value and 83% of negative predictive value with area under curve of 0.996, which is very good for any serum tumor markers. And it is expressed in almost every testicular tumor except teratoma. Although these genetic studies, because they are polygenic and they are basically multi-stage, so still we don't have too many genes to target to cure all these patients. And there could be another reason also less. According to the Globocon data, so the worldwide, or especially in the Western world, the incidence of the testicular tumor is roughly around 5 to 6 with the cure rate of the 95%. In another study, it has been found that the incidence of all Western countries, they are higher with the compared to the India. So the incidence of India is in this yellow line, which is almost consistent from the 1978 to 2002. And it is roughly hovering around 0.5 to 1 per 1 lakh of the patient. And if you see the adjusted standardized incidence and mortality rate of the patient per lakh, then the incidence of the testicular tumor in India is negative compared to the Western world. But if you'll see the incidence of the testicular tumor in India, Indian perspective, then it is still most common malignancy in the age group of 15 to 35 year age of the patients. It almost constitutes 0.3% of the all cancers, and it ranks 31 among all the cancers in Indian scenario. Whereas the incidence of the testicular tumor in India varies from 0.5 to 1 per lakh population. So if you see the survival analysis or survival of the testicular tumor patients in the Western world, it is almost roughly around 90 to 95%. But the scenario of the testicular tumor or the survival of the testicular tumor is totally different in the Indian patient. This study is from the Kolkata, TMC Kolkata, where they just studied the epidemiology of non-seminomatous germ cell, and they found almost 50% of their patients, they came in the stage 3 of the disease. And if you'll see the risk stratification, then almost 20 to 30% of the patient, they fall into the poor risk stratification of the IGCC score. Whereas almost every patient of the stage 3 got the chemotherapy, but still almost 6% of the patient, they progress, whereas almost 4% of the patient, they do have only stable disease on the chemotherapy. If you'll see the survival, then overall 3-year survival is roughly around 78.2%, whereas stage-wise specifically, if you'll see the survival of a stage 3 patient varies from 68.8%. Another paper from TMC Bombay, it analyzed the seminoma as well as non-seminoma also, but story is almost same. It is not different at all. Almost 50% of the patient, they came in the stage 3. And almost 30 to 40% of the patient, they come into the intermediate or poor risk of this disease status. And almost every patient is having metastasis to the lung or lymph node in stage 3. So if you'll see in the Western country perspective, the eligibility criteria for having a screening test, then I would say testicular tumor does not basically qualify for having any screening test because it doesn't have a very high incidence. So it is not a basically social health problem over there. And even if you are having a testicular tumor, you can cure with all these therapy available, be it a surgery or chemotherapy, even in a later stage also. So the benefits and harms of doing screening in Western world is totally different, because in literature, there is no study, be it a case study or cohort study or a randomized study or a meta-analysis, which has analyzed the sensitivity, specificity, or positive predictive value of the screening, be it a testicular self-examination or ultrasound. It is not known yet. And it is also not proved that early diagnosis resulted in survival benefit of all these patients. In one study, which was a single center study, where almost 1,300 patients underwent the ultrasound for testicular lesion, and almost only 2% came as positive, out of which only 17 patients had a palpable lesion, and who underwent the biopsy, ultimately only 20% patient had a malignant lesion, with the positive predictive value of 0.2. So with this kind of the statistics, so you cannot have any screening method, be it a testicular self-examination or ultrasound in Western world. So that's why US this Preventive Service Task Force provided the recommendation of D for any sort of screening methods for testicular tumor. So it outrightly denied for any screening in Western world of the patient. Similarly, the EAU does not have any basically recommendation for the screening, but it do have a recommendation for high-risk patient. That means those do have a family history or a testicular tumor in opposite side in the past. Similarly, AUA doesn't have any statement for the screening. It only states that those patients who had a cryptorchidism, they do every monthly testicular self-examination to identify any like abnormality in their testis, and NCCN even does not have any statement about the testicular self-examination or ultrasound of the testis as a screening method. But in like I would ask all these questions for our perspective, Indian perspective. So in our perspective, although the incidence of the testicular tumor is less, but our patient, most of these patients, they are coming in higher stage, be it a stage 2 or stage 3. So although incidence is less, but they are coming in a very late stage, which affects their survival. So I would say in our patient, we must have a screening procedure. And another question, if we can identify all these testicular tumor in the early stages, be it the stage 1 or stage 2, we can give them chemotherapy with lesser intent, with the less number of the cycles, and probably they would not require any post chemotherapy or RPLND or any adjunctive surgical procedure to cure the disease in all these patients, which ultimately add on to the morbidity of all these patients. And do we have basically any method to screen all these patients? Then definitely answer is yes. We have a testicular self-examination, which is basically does not have any cost, which can be done by the patient if he has been taught a very basically in a good method to do a testicular self-examination, or it can be done with any like physician or surgeons if the patient comes to the clinic for some other purpose also, just like opportunistic PSA screening also. So my answer to screen, why to screen all these patients? Because early detection may decrease the number of the therapy. It may decrease the numbers or the cycle of the chemotherapy. It like evaluate this basically decrease the extent of the surgery. Patient may not require a surgery at all for the post chemotherapy masses, and we can prevent all these patients to have a higher stage of the disease or poor survival. Because we have seen in our data that almost those patients who are coming with the stage 3, they are almost having 73 to 78% of the survival 3-year OS of all these patients. And testicular self-examination is a very simple procedure which can be done during the bathing every month. So you can examine your testis, you just roll your finger, just feel any abnormality in the testis. If you do find any abnormal finding into the testis in form of any lump, any hardness or anything, you just required to consult your physician or surgeon as soon as possible. So in conclusion, testicular tumor is polygenic, multi-step in nature, that poses a challenges for the physician to target the therapy, basically to target the testicular tumor. Most of the patients, they come to us at a higher stage, which require like multiple line of chemotherapy in form of 4 cycles of the BEP, or they may require a second line of the chemotherapy also. They may require adjunct surgical procedures also. to cure or to remove the post-chemotherapy lymph node. And opportunistic screening in high-risk patient is warranted in our country. And this testicular self-examination is the most cost-effective method. So in my opinion, we must have a basically testicular self-examination as a screening tool for all testicular tumor patients who are basically having in high-risk group. Thank you for patience hearing, sir.
Thank you, Amitabh. Quite a comprehensive presentation. I invite Dr. Sudhir Raval, sir, for his comments.
Yeah, thank you, Ganesh, and thank you, Amitabh. It's a very comprehensive presentation which you have done. About genetic and all, I think to target a specific microRNA will be there soon. I heard this talk a few years back in GU ESCO, and it's there in the literature. And I think this will be very good tumor marker in future, better than your beta-HCG and AFP, as he has already mentioned. The other thing that about testicular self-examination, I think problem is of the awareness. The young kids, they are not educated. They don't know what is happening to them. They ignore themselves. And I have seen way back in my practice, a young boy who is now doctor came with a huge lump in the abdomen, and he was actually on table in Balrampur Hospital, Lucknow. They were doing surgery, but suddenly father said, no, I'll take him to Delhi. He came to us and I examined his testes. There was a big scrotal mass. I said, why didn't you complain about this? He said that I thought it is because of the hormone, my testes is increasing. So there's the knowledge of the testicular swelling is. Another thing that many times the general physician or maybe practitioner may not be knowing that how to even elicit the testicular sensation. If there's testicular swelling, it can be because of anything. It can be because of a tumor. It can be because of something else. So the differentiating factor is testicular sensation. And I still remember my MBBS days when few doctors and medical students will come in a this was not the entry from competition. They used to have nomination type of candidate, and many of them, they will, when you ask them that how do you elicit the testicular sensation, they will put a alpin on or a safety pin or pin on the scrotal skin, and they will say this is how you induce. And to my surprise, I was taking a MCH class a few months back, and the presenter who was MCH trainee, when I asked how to elicit the testicular sensation, he didn't know. So this is what we have to stress on, not only the awareness, also to the medical fraternity, that just don't ignore the clinical examination, which is very important in these patients to differentiate that about if the patient has got testicular tumor or the swelling is because of something else. So these are a few words. Already Amitabh has mentioned a lot of about genetics and mutation. There's no hardcore things is going on. Maybe in future we will have something on these in these type of cancer. But when the patient comes in stage 3, the survival outcome is not as good as if the patient is coming in stage 1 and 2. So there is a need for taking care of these kids, to educate them, to educate the doctors also, so that they can be captured early and the outcome will be better. Thank you.
Thank you, sir. Over to Dr. Raghunath, who is our SOGO secretary, for his comments and closure.
Thank you, Ganesh. I would take just 2-3 minutes to summarize. It was an excellent program, very well curated program. I must thank all the coordinators, Dr. Ragavan, Ganesh, and Dr. Sanjay for this. To summarize, for prostate cancer, in India, the prostate cancer is very relevant, and opportunistic screening is definitely required. And the need of the hour is to create awareness to reduce the mortality. We know in India, mortality is very high. It's close to 50 to 60%. So awareness is definitely required. When it comes to bladder cancer, the screening is required for at-risk population. Who are the at-risk population? Smokers, those with history of industrial exposure, microscopic hematuria, but we are not getting microscopic urine analysis to identify this microscopic hematuria. if we implement at least urine analysis as a screening tool to detect, then we can probably pick up microscopic hematuria. And we do see a lot of patients with indwelling foreign bodies. Most of our patients will have, at least in oncology, long-standing stents. So probably we should focus on these things to pick up bladder cancers early. And need for primary and secondary prevention is very important. When it comes to penile cancers, very well, spoke about Atmanirbhar. Definitely, we need to go in that direction. We do not have much data on this, but SOGO has taken a lot of measures to collect our own data. We have already in the process of collecting retrospective data on few cancers. Dr. Ragavan, Ganesh, and Sanjai are working on those things. When it comes to renal cancers, the incidence is increasing, and even though the higher grade tumors we see compared to 50 years back, the incidence is now almost doubled. And USG is very important. And Dr. Srivathsan highlighted on utility of AI. Probably it's going to come in a big way. With this, probably we can pick up more tumors. You all would agree with me that most of the partial nephrectomies we do for small renal masses now, they all come with ultrasound report, all detected with ultrasound reports. Unlike what is reported in our textbooks, generally RCCs would come with the pain, abdomen, and hematuria. We don't see any of those things for at least early tumors. So definitely ultrasound is very valuable tool for screening. And lastly, testicular tumors. Dr. Amitabh spoke very high about these genetic markers and all, but screening is not recommended for this, as the incidence of this testicular tumor is very less, and even the outcomes, if detected in the second stage or third stage, outcomes are relatively better compared to all other cancers. But he also highlighted on the testicular self-examination, which is recommended. We must probably create awareness amongst the college students about self-testicular examination. MicroRNA and all these genetic markers, tumor markers may play a bigger role in future. So I must thank all the speakers and experts and all the SOGO members, particularly our coordinators, Dr. Ragavan, Sanjay, and Ganesh Bakshi for curating this program so well. I also thank all the participants on this working day. The more than 60 participants were there. And this program is apt for this month, this November month. This was required. And in the recent past, probably we never come across this kind of programs. It's good that we conducted, we had this kind of a webinar to create awareness and screening. In fact, this was really an eye-opener for all of us, because we never had this kind of programs in any of the forums. Okay, thank you all for doing this and for your participation. Good night.
Good night. Thank you.
Night, David.